Thank you. And I'm very happy to present this project that is a practical realization of what the two projects were talking about, especially Louise, because we are practically realizing what would be to apply gender and sex measurements in a clinical project. And oh, this one? Ah, okay. No. This one? This one, just to remind me that I started from Brussels in 2020. Before the pandemic, I was invited to present G-Definer by a group of patients advocates, and then I'm finishing to present G-Definer in Brussels again. Please, Hannah.
Okay. Thank you. I'm Hanna Eriksson. I work as an oncologist at Karolinska University Hospital and Karolinska Institutet in Stockholm. So the background to this project is that we have a relatively new group of treatments in cancer, and these are the immune checkpoint inhibitors. And this is a group of antibodies that actually block the break of the immune system, especially of the T cells. And in the natural situation, we need to have this break so infections and inflammations doesn't cause tissue damage and autoimmune diseases. But now we also know that the cancer itself actually induces this break to protect itself from the normal immune response against the cancer. And therefore, these checkpoint inhibitors have been so successful, not just in one type of cancer, but now we can use it as a backbone for therapies and almost all types of cancer as monotherapy or alone or in combination with different checkpoint inhibitors or more traditional systemic therapies like chemotherapies and targeted therapies. And also the efficacy has been great with durable responses from early disease to more advanced cancers. So this is a really breakthrough for cancer patients and of course also for us as treating the patients. But the back side of the coin, is of course that we have a specific new group of side effects that are caused by an unspecific immune response. We of course want the T cells to react against the cancer, but then we have inflammations or autoimmune side effects, and these can basically affect all organs in the body, and we are grading them according to the severity, and moderate to severe side effects can be or cause treatment interruptions, hospitalizations of the patients, and also that they need to receive quite high and potent immunosuppressive drugs. And we also have patients that actually die from these side effects. But again, in clinical trials, we both have men and women in the clinical trials, but we know very little about the difference and the outcomes between men and women, both biologically. Most of the clinical trials are based on the type of cancer and the molecular status of the cancer, and we have no information at all on the gender perspective of these side effects. So the Gender G-Definer Consortium consists of 4 institutions. We have in Ireland the St. Vincent's University Hospital, and in Norway the University Hospital of Oslo, and of course in Italy the National Foundation of Cancer in Milan and Karolinska Institutet and University Hospital in Sweden. And the main aim of the study is to investigate inequalities of immune-related toxicities between men and women receiving these therapies. And we look at incidence, type, and grade of toxicities, but also taking into account biological and also sex and gender aspects of the cancer and side effects. So this is a multidisciplinary study trial, including medical oncologists, biostatisticians, biologists, and preclinicians. And we have several postdocs and students included in the trial. So the first year of the study, because this was a unique opportunity to get funded to really study these questions, is that we had to write a protocol that also would, of course, be approved by the different ethical committees. But this was just when the pandemic started, and the pandemic has influenced the trial a lot, because it has been performed, the patients have been included and followed, and in a total clinical setting. And almost all nurses and doctors at this time point had to be involved in the pandemic wards instead. And also we have built a case report form, an electronic case report form that could be international and work between the different institutions. And then also we had to formulate the SOPs for the biological sampling. And to combine all these questions with the biological aspects, it took almost a year for us. So by January this year, we have a preliminary interim analysis. We stopped to include patients just a couple of weeks ago, so the follow-up data are still maturing. We aimed at including 400 patients, but we had power in the study for patients, 200 to 400 patients. And we screened 262 patients, and 10 patients didn't sign the informed consent, and we had 4 screening failures, and 1 patient that actually got an infection and couldn't participate, never started the immune therapy. So in total, 247 patients were recruited, and we could, in this interim analysis, include 204 of these patients.
Yes, thank you, Hannah. And I just want to remind you that all the CRF, the protocol of the study, of course, the CRF, the SOPs are available on the Zenodo platform, publicly available for the researchers. And in this case report, we mentioned all the intersectional variables that we have collected during the study, because the study has a wide breadth of data, both clinical and biological, and they were collected at the baseline, at the outpatients visit, and also collected with the medical charts related to demographic, comorbidities of patients, disease and treatment characteristics, of course, follow-up. And we have also collected prospectively the data at time at the first infusion of immunotherapy, and what we are collected about the psychosocial and behavioral variables are measurement of quality of life, distress, diet, also eating habits that are related to microbiota. This is one of the aim of the project. Also personal sense of being, ethnicity, marital status, living arrangement, and so on. All those variables that are related to what Luisa was talking about. That are intersectional variables that can interact with sex to determine the outcome of immunotherapy in terms of adverse events occurrence. We also have collected lab variables, also gene expression, because the patients are taking blood and feces samples, so we are collecting these samples to perform biological analysis such as gene expression, SNPs, microbiota, and cytokines. And these are some of the results of the study. These are some key features associating significantly different between female and male patients populations. And we have, I just want to highlight some diseases that patients had at the baseline, such as coronary heart disease, or also there were some differences in settings of administration of immunotherapies. Men has immunotherapy administered in earlier settings, and also another surprising difference is that women are interrupting immunotherapy more frequently than men, and this is because of the occurrence of adverse events. So this is why this was our hypothesis, that women are more affected than men, have higher occurrence of adverse events. These are also other key features significantly different between female and male population related to the intersectional variables. We collected personal sense of being, but there were no differences between male and female populations, but we have some differences in marital status. Men are declaring to be in couple more frequently than women, and also we have some differences in income. Men are earning euros, this is the quantities in euros, and they earn more than women. And then we have also differences in body mass index, and also in physical activity. Women are performing very low differences, very low physical activity levels. And also we have a correlation between living arrangement and marital status, because people that are declaring to be in couple are also living with partner and with or without children. And we also have, I cannot see well here, living arrangement, yes, that in which men are declaring to live with partner more frequently than women. And also we have a higher percentage of widowed female in this sample than men. This was what we were observing in the other studies. And these are some quality of life related factors that we were collecting. And the first one is measuring which is the health of patients, also the capacity to self-care, usual activity, pain, discomfort, anxiety, and depressions. And the other scale is measuring other kinds of problems, practical family problems, emotional, spiritual, religious, also, and physical. And we selected with a machine learning algorithm the most important variables that were related to be female and male in the sample, and we discovered that female are affected more frequently than men of fear. They're fearful. Perhaps this is related to the disease, of course. Oh, sorry. And also the other characteristics related to quality of life that allows us to build some weighting to perform the analysis. This is a parallel with what I observed yesterday in Future Gen Navigator findings, that in which we see that females are affected more frequently than men in the daily activities, is what we observed in our study, and also that this is a difference in income between male and female. This is perfectly adherent with what we observed. This is also to make you understand that sex is an independent factor related to quality of life, independent of all those factors, intersectional factors that we examined. Also, we have that women at baseline have quality of life levels worse than men, and they are worsening after the first infusion of chemotherapy, of immunotherapy, immunotherapy, and men are starting with better quality of life respect to women. And this is the measure of burden of adverse events, in which we see the difference between female, significant difference between female and male. Female have a higher burden of adverse events. And this is in univariate analysis and also in multivariate analysis, adjusting for all the characteristics. This is an example of interaction between the sex and other related factors. And we see that, I just want to show this one, in which we see that female has a higher burden of adverse events, and that female with less or with severe problems of anxiety and depression has less burden of adverse events. This can be related to the immune system that is more compromised in women with anxiety and depression, and this leads to have less adverse events. And I can skip, this is related to higher incidence of adverse events in general. The first adverse events of grade G greater than 2 that needs necessary the treatments for these patients. And just to leave the floor to Alex to summarize the biological analysis.
Hi. So briefly, as part of this, we collected biological samples. These were blood samples taken at different time points. So you can see that at the start of treatment, a blood and fecal sample was taken, then at the first ICI treatment, and then we also took when patients actually had a adverse event of greater than 2. So we collected samples across this study, and as a result of concerns of bias of us actually analysing at different stages, we're only actually coming through to analyse those samples now. So currently we have matched T0 and T1 samples from 214 patients, and in 42 cases where patients actually had a T2 event, we've collected samples from those as well. So the analysis we're hoping to do is to have a look at basic lab assessments, having a look at the blood work of patients, which can give us information in relation to inflammation and biomarkers, which could be predictive of those patients that go on to have adverse events. The gene expression analysis, using in silico analysis, we can actually use programs such as CyberSort to go back and quantify in an in silico manner the immune contexture of a patient's cancer as well, or of their blood, sorry, and we can actually measure that out afterwards to see how that changes as a patient's treatment progresses. And we can also look at single nucleotide polymorphisms. These are just SNVs that differentiate us as a human population to identify if there are any common SNVs which may actually be important in relation to those patients who receive or who go on to develop an adverse event as well. So that analysis is starting in the next couple of weeks. We're just collecting up the final samples as we only finished recruitment in the last couple of weeks itself. So that's going to be our next step. Subsequent to that, just an example of this is if we focus into the red square down at the bottom, you're having a look at different colors. It's very elegant, but on the left-hand side is a pre-treatment, on the right-hand side is a post-treatment. And the different colors represent different immune subsets that are actually there. And what you can see is between the baseline and the first level of treatment, the immune contexture actually changes between the patient. So we're obviously seeing then that this immune response is going to be important, but if we can do this in enough patients, we can try and correlate that back then to see which patients had an adverse event and to see if there's a particular immune subset which is involved in that as well. I think that's,
yes, if you want.
yeah, that's fine. And just in relation to future plans, the database has been followed up at the moment, and we're just finalizing that in the next couple of weeks. We're going to really kind of deepen the analysis, and the conversations we've been listening to here and the different presentations have really kind of allowed us to look at the psychosocial aspects of that, which initially we were very much focused on collecting the clinical data, but the associations between things such as fear, which we've identified, particularly in women who are going on to their treatment, and how that can probably impact as well on how quality of life is impacted. That's going to be important for us as well. The biological assessment is important, and obviously afterwards to work on predictive models in relation to the adverse events. And I think on time, we're going to say thank you very much.
You can skip, we can talk about
Yeah.
in the discussion about these factors. Okay.